Hello, everyone. Welcome to TP Recap VMR. And today I, Glenn, and Julia would be summarizing the VMRs from the last month. And I really hope you all enjoy. And Glenn and Julia, would you like to introduce yourselves, please?
Hello, everyone. I'm Julia, medical graduated from Brazil. I'm very excited for today's teaching point recap.
Hello everyone, my name is Glenn. I'm a medical student in Botswana, Southern Africa. Excited for today's today's session rather. I'll be summarizing one of the cases for this month.
Okay, it's really great having you guys do the recaps. And Glenn or Julia, would you like to go first and start sharing your screen? We are very excited for your recaps.
Okay, let me share my screen.
Glenn, I think you're muted.
Sorry for that. Okay, to start us off, sorry for forgetting to share to unmute rather. So I'll be taking you through a case, summarizing a case occurred last month on the 4th. Was presented by Vinny and was discussed by Xavier and Steph. So going on to the first part of my problem presentation.
Yeah, seeing our screen.
You can't see the screen. It's
Not
not
yet.
visible yet.
No.
It's not visible. It's okay. Can someone please take over, then come next, just to
Yeah,
sort out
I can start sharing my screen.
Okay.
Just a second. So hello everyone, I will do the teaching points recap from the case presented on June 19 by me and was discussed by Rabi and Lyra. So starting with the case, was a 35-year-old male with no past medical history who presented with acute shortness of breath, progressive dysphagia, and inflammatory symptoms. The progressive dysphagia started 7 months ago and with solids that progressive to liquids. Also, the inflammatory symptoms were weight loss and night sweats. So to start going to this case, we can divide the symptoms to better understand what is going on here. So for the acute shortness of breath, we can think about heart and lung problems that could be causing this. For example, heart failure or COPD. Also, from the progressive dysphagia, we can divide in oropharyngeal or esophageal dysphagia. And with all of this, the symptoms together, shortness of breath, progressive dysphagia, also with these inflammatory symptoms, we should always think about mediastinal, such as air or mass that could be compressing. If we are thinking about all of this, so the mass could be compressing the air system and the esophageal. So now, talking more about the approach for dysphagia, we have two approaches. The first one is to understand if this is a motility or a structural problem. For example, if the patient had a motility disease, this patient will have difficulty with both solids and liquids without difference between the both. And in the other hand, if the patient had structural disease, the dysphagia will start with solids and then progressive to liquids. And Robbie, have this amazing discussion about this, because with that in mind, we can understand that this case could probably be a structural disease. Also, the approach to dysphagia involves oropharyngeal versus esophageal disease. When we have an oropharyngeal disease, this is commonly associated with aspiration pneumonia or consequences. And in this case, for example, that this patient had 7 months symptoms of this patient, this is very unlikely to be a oropharyngeal dysphagia because this patient had no aspiration pneumonia, neither consequences from this. So in this case, should be probably an esophageal dysphagia because this patient had more localized symptoms and without aspiration pneumonia or consequence. And with all of that in mind, we can conclude that this case was a structural disease in the esophagus. So going on to the physical exam, the vitals were relevant for respiratory rate of 32 and saturation of 62. Also in the physical exam, we saw decreased breath sounds and mild wheezing on the left. And on the musculoskeletal, we had mild proximal muscle weakness, and the patient required intubation because of this hypoxemia. Also in the initial labs, we had white blood cell count of 52,000, together with electrolyte abnormalities such as hyponatremia, hyperkalemia, AKI, low calcium, elevated uric acid, and also elevated lactate and LGH. And all of this makes we think about tumor lysis syndrome or something that could be causing all of these electrolyte abnormalities. And with all of this in mind, you can put in the chat, what are your thoughts about this case? What do you think that could be causing all of these symptoms? So going on to the image findings, we had a chest x-ray that revealed a tracheal deviation to the right, and also multiple bilateral opacities, as we see here. And also we see that both diaphragm are elevated. And we can analyze this because tracheal deviation without pulmonary or pleural disease can be due to positional change for the patient or mediastinal disease. Also, when the patient had both diaphragmatic elevation, this could be because of poor respiratory effort or even bilateral diaphragmatic weakness. And when does that occur? This bilateral diaphragmatic weakness can occur when there is a mediastinal mass that could be compressing both phrenic nerves, causing this diaphragmatic weakness. Also, we can analyze the ABG that was done. We had acidosis with elevated PCO2, a low PO2 together with low saturation. And all of this was brilliant explained by Rabi and Lyra, that this is a mixed hypoxic and hypercapnic respiratory failure because we had low oxygen saturation, low PO2, together with a high PCO2. Otherwise, we had the CT test that revealed a large anterior mediastinal mass, and a biopsy revealed a poor differentiated neuroendocrine tumor positive for synophysin and chromogranin A. And with that, we had the diagnosis of poorly differentiated neuroendocrine carcinoma, likely from this mediastinal origin, complicated by tumor lysis syndrome. It's a big name that I will explain the next slides. So this CPS scheme is really helpful to understand the mediastinal mass. We can divide the mediastinum into anterior, medial, and posterior, and we can have different diseases in each of these parts of the mediastinum. For example, in the anterior, we can have thymoma cancer, teratoma, and so on. In the medial, we can have lymph nodes, also cardiac disease, esophageal mass. In the posterior, we can have things with the bones, and also neurogenic tumors. And one important mnemonic here to remember the things that can be going on in the mediastinum is the terrible T's. We have 5, that is thymoma or chemicarcinoma, teratoma or germ cell tumor, terrible lymphoma, thyroid, and parathyroid. And with that in mind, we can easily remember what could be going on within the mediastinum. So going to the neuroendocrine tumors, we can divide them in indolent and aggressive. The indolent, we have a lot of them, including well-differentiated neuroendocrine tumors, such as carcinoid and atypical carcinoid. Also, we can have this well-differentiated pancreatic tumor, such as islet cell tumor, medullary carcinoma of the thyroid, paraganglioma, and pheochromocytoma. And in the space of aggressive tumors, we have the small and large cell lung cancer. We have the high-grade, poorly differentiated neuroendocrine carcinoma that was the diagnosis in this case. Also, extrapulmonary small cell lung carcinoma, market cell tumor, and neuroblastoma. And here we have also a CPS schema that is really helpful for us to understand the neuroendocrine tumors. So we can have hyperplasia, and the neuroendocrine tumors can be divided in differentiated and undifferentiated. The differentiated, also called NAT, could be the GI and others, and the undifferentiated, also called NAC, we have the pulmonary, such as small cell cancer and large cell cancer. We have the market cell and other ones, such as neuroblastoma and undifferentiated neuroendocrine tumors. So now talking specifically about the high-grade, poorly differentiated neuroendocrine carcinomas, the NACs. They are called high-grade because on the microscopy, we see a division of more than 20% of the cells. Also, we call them poorly differentiated because in the microscopy, we see that the cells are very immature. Also, these are the most aggressive cancers within the neuroendocrines, and they are widely metastatic. One important thing here is that they can arise anywhere in our body. So the symptoms may vary depending on where they are located. And 1/3 of the cases, we will not find the primary site of the tumor. Rarely the symptoms will produce some bioactive substances, but this is really rare. The diagnosis, as I mentioned in the case presentation, is done by immunohistochemistry staining for chromogranin and synophysin. And another important thing is the treatment does not vary based on the primary site. And this means that whatever the site is, the treatment will be chemotherapy. So sometimes we will try to find where the primary site is, but if we do not find, that will be okay too, because the treatment will not vary. So this is really important to talk with the patient and have this in mind. So some take-home messages: the symptoms of respiratory failure together with dysphagia and inflammatory symptoms, we should always think about mediastinal mass compression. Also, neuroendocrine tumors can arise anywhere, and the symptoms may vary based on where they are located. For example, in this case, this patient had symptoms of mediastinal compression. Another thing is that these tumors are highly aggressive and can lead to tumor lysis syndrome spontaneously or after starting chemotherapy. So always think about neuroendocrine tumors when the patients are having tumor lysis syndrome spontaneously. And these are my references. Thank you, everyone.
Thank you, Julia. That was phenomenal how you walked us through the case, but also taught us about neuroendocrine tumors. We absolutely loved it. Glenn, would you like to go next? Glenn, would you like to go next? Are you able to share your screen now? Or should I go next as you
Yeah,
prefer?
please go next. I'm still fixing something.
Okay, sure. So friends, today I will share with you a recap of a case that I presented on Alex's behalf to Rabbi and Zachariah, and I'll just start sharing my screen. So can you guys see my screen?
Yes.
So this is a case of cloudy belly with a cirrhotic twist, and it was discussed by Rabbi and Zachariah, and I'll just try to give a brief recap of what we talked about. So I want you all to meet our mystery patient, who was a 65-year-old female who presented with cirrhosis history, walks in with tense belly for 1 month, with swollen legs and history of recent UTI, but something quite doesn't add up. And what were we thinking at this point? We were thinking, was it heart failure because the patient had swollen legs, swollen belly, but there was no shortness of breath? We were thinking, is this infection? Is this malignancy, or is it something else? So we decided to crack the case by thinking about what problems do we have. So first thing we had was an elderly female. She had distended belly and swollen legs. And then there were these pelvic symptoms that we were having. So one thing I really want to emphasize here is that diagnosis of a pelvic mass can be easily missed in postmenopausal women. So whenever we have a postmenopausal women with pelvic symptoms, we should always think about the pelvic mass. And so that is something I really wanted to emphasize on. As for the distended belly, we were thinking whether it is solid, liquid, or gas. And gas usually presents more acutely in form of ileus or obstruction. And here the problem had been going on for 1 month. And for solid, we usually have more focal symptoms, such as if the liver is involved, we will have hepatomegaly. If the spleen is involved, we will have splenomegaly. But here we were having a more diffuse abdominal distension and more diffuse picture. So we were thinking about liquid. And as for the pelvic symptoms. So we were thinking that the urinary tract seems to be irritated because patient was having dysuria. So we were thinking whether it is irritated from the inside the lumen by bacteria or from something from the outside the lumen, but inside the body, such as mass. So that was what we were thinking about right now. And then the exam showed some dullness to percussion, which took us further towards the ascites hypothesis. So what you guys think was the cause of ascites? Feel free to unmute or share in the chat. Was it due to heart failure, SVP, decompensated cirrhosis? Was it chylous ascites, or was it TB? Feel free to unmute, or if you want to share your ideas in the chat, feel free to do that. So let's now crack the lab clues we had. So when we have milky fluid, we have to think whether it's acidic fluid or coconut milk, obviously not coconut milk. So paracentesis was done and fluid was found on focus, and it showed that there was milky fluid. We had high SAG ascites and WBCs were elevated at 700 with lymphocytic predominance. And when we have elevated WBCs, usually we think about SBP, spontaneous bacterial peritonitis, but that has a neutrophilic predominance. And here we had more of a lymphocytic predominance. And acidic fluid albumin was low, but the protein was not very low. So there were some other lab results as well, that X-ray was normal, CBC, basic metabolic panel was normal, and bilirubin was normal, and we had mild EST, ELT elevation. And how it helped us think about the differential was that we were less thinking about decompensated liver failure because the synthetic function of liver was not affected. We had no jaundice, we had no bleeding, and the liver function tests were only a bit elevated, and we had no signs of hepatic incap in this patient, and then urine analysis and culture confirmed UTI, which was treated. So it was quite reassuring that we do not have something serious going on because of the pelvic symptoms, and CT abdominal pelvis was also normal at this point. And let's just break down how can we think about ascites. So when we have ascites, we can think about high SAG ascites, and the causes include prehepatic, intrahepatic, or posthepatic. Or we can think about low SAG ascites that can be seen in sinusitis or organ-specific causes such as renal, GI, infection, autoimmune, and cancer. But one thing I really want to emphasize here on is that when we have high SAG ascites, chyle is also something we should have at the back of our mind. And so how to explain what we had on paracentesis in this patient? So we had mainly high SAG milky ascites at this point, and there was some signs of inflammation because there were WBCs with lymphocytic predominance. And the next question here was that, are these lymphocytes activated or are these lymphocytes inactivated? So when we have lymphocytes activated, we have increased LDH and ADA level in the acidic fluid, and that is seen in TB, malignancy, and certain infections. And when we have lymphocytes which are not activated, we will have low LDH and ADA level. And these can be seen in traumatic causes due to venous hypertension, also can be seen in chyle. So given the milky fluid here, high SAG ascites, we were thinking about getting the triglycerides level and also checking LDH and ADA so that we can know whether the lymphocytes are activated or they're just inactivated. So further, we got some labs, and acidic fluid triglycerides were above 200, and when acidic fluid triglycerides are more than 200, we think about chylous ascites. So that was something we were definitely thinking about, but LDH and ADA were normal, which was taking us away from infection and malignancy, and imaging was also normal. So due to high acidic fluid triglyceride, low acidic fluid albumin, and high acidic fluid protein, final diagnosis of chylous ascites was made. And chyle is mainly the fluid which is moving in the lymphatic system, and it is high in protein, high in lymphocytes, but is usually low in albumin. So important clue here was also that high SAG ascites with high protein and high triglycerides also takes us towards chylous ascites. So just a brief summary of what chyle is. So chyle is mainly a transport medium for lymph, and it has high protein, low albumin, and WBCs are elevated with lymphocytic predominance, and Sag-Stover score is more than 1.1. So one caveat here was that high protein can confuse it with exudate, but albumin is usually also high in most cases of exudate, and triglycerides are not usually very elevated, more than 200 in exudate. So we were more thinking about chyle here. And we will talk about the causes of chylous ascites. It can be traumatic, it can be due to inflammation, which causes chylous leak, or maybe due to venous hypertension, which seemed to be the case here. And so from confusion to chyle case in a nutshell. So a rare cause of chylous ascites is venous hypertension that can be diagnosed by milky fluid, triglyceride more than 200, and lymphocytic predominance, and patient improved with diuretics and paracentesis. And I just have a few take-home points for you that whenever acidic fluid triglyceride is more than 200, we should always think about chylous ascites, and not all WBCs mean SPP. Lymphocytic predominance can also make us think about chyle, and high protein and low albumin in acidic fluid are also something that can help us think about chyle. However, it is rare, but should always be at the back of our mind, and we should rule out malignancy, TB, and pancreatitis. And thank you so much for joining, everyone. And I hope you got to learn something from this recap. And I'll stop sharing the screen here. Glenn, would you like to share your screen if you can right now? If not, you can just recap it without the screen and we can learn from you.
Let me try going out of the meeting then.
So friends, while Glenn is gone, do you have any reflections or any thoughts or any questions? And everyone who is joining, thank you for joining, and we would like you to present a case and join us.
Okay, can you all see my screen?
Yes.
Okay, thank you everyone for being patient with me. So I'll be summarizing a case on the 4th, which was presented by Vinny and discussed by Stefan and Xavier. So I divided my problem presentation into two, so I'll be taking you through the first part of the problem presentation. So we had a 74-year-old male with fatigue, recurring low-grade fever. I was hospitalized for non-productive cough, fatigue, weakness for 3 weeks. I had a chest X-ray which showed an opacity on the left lung base. So the patient was readmitted for the same symptoms. Had continued fatigue, fever, and chills. Also had weight loss, nausea and vomiting, headache. Had some nose bleeds. Showed acute sinusitis. Had past medical history of ITP, glaucoma. The physical exam was normal. So from here, just the broad differentials that you can have. So from the problem presentation, any differentials you can have, you can divide them into infectious, autoimmune, and malignancy. And malignancy just added it because the patient is a 74-year-old woman, so the lymphomas, leukemias common in the elderly, and then also infectious causes, TB, fungal, and bacterial. The autoimmune causes, especially the granulomatous autoimmune infection. So from here, I just listed some of the broad differentials that you can have. If anyone has any differentials in mind, you can share in the chat. And also from here, you can then think of the next test that you can order, and you can also include in the chat if you have any differential and any test to proceed with. So for some of the appropriate tests that we can do, looking at the differentials that we have, start with the CBC with differentials. For infectious and inflammatory causes, just check ESR and CRP, check if any inflammation going on, do infectious workup, check for rule out things like TB, autoimmune, check the anchors actually. That was one of the differentials that I had in the last slide, and any imaging for malignancy, especially the fact that the patient is old. So going over the second part of the problem presentation. So we can notice that there is some mild anemia, and also, but the MCV is normal. There is elevated CRP and ESR, which points to more of an inflammatory cause. There's also low C3 and C3 and C4. However, the anchors are negative, and infectious causes like HIV are negative. And then when the CT of the face was done, that's when they confirmed the vasculitis, some thickening of the left subclavian and the common carotid. Also confirmed that with the CT of the chest, which also confirmed vasculitis. So in the end, they came to a conclusion of a diagnosis of giant cell arteritis. So I included the schema for vasculitis. So once you have a differential of vasculitis, one of the things that you can think about. So you can classify them into small vessel, medium vessel, and large vessel. For the small vessel, majority of them will involve the renal system, and they will cause glomerular nephritis. And the anchors also, they can also involve the respiratory system as well. Things like there's also IgA nephropathy, which is common in children. Cryo as well, cryoglobulinemia. Also check skin finding for leukocytoclastic vasculitis. For the medium vessel, Vasculitis, you think of polyarthritis nodosa, which usually present has some GI symptoms, can cause some neuropathy as well, can also involve the kidneys. We also have thromboangiitis obliterans, which is common in smokers and can give a gangrene-like picture. Also Kawasaki, which is common in children, which can present with a strawberry tongue and some skin findings as well. So for the large vessel, which we saw in this case, can either be giant cell arthritis or Takayasu arthritis. So usually for these two, to differentiate the two clinically, the giant cell will be most common in older women. For Takayasu, it's more common in Asia women and usually involves the vessels exiting the heart. So the aorta, subclavian vessels will affect those kind of vessels, and then some causes can involve variable vessels, such as SLE and rheumatoid arthritis, and others are included in the screen as well. Okay, so, to finish off this case, there's some take-home points. So, giant cell arthritis, as we saw in the case, can mimic any differentials like infections, malignancy, presents with some constitutional symptoms. One of the clues that can point to giant cell arthritis is look for a headache usually in an older adult, and usually it's around the temporal side, and can also complicate with eye findings and can cause look for any problems with vision, and can also present with other unspecific symptoms, cough, sinusitis, anemia of chronic disease. These are the things that are common and can delay the diagnosis. So that's all I had. Thank you so much.
Thank you, Glenn. That was amazing. And vasculitis is something I really struggle with. And thank you for making it so easy for us. And we loved it. And I really want to thank Deborah and Elena for making this happen today as well. And thank you all for joining, and see you tomorrow. Have a great day. Goodbye.